Yeah, great. So, well, I think that my talk follows on very neatly to what we've just heard from Wolf Henning, in that, and as I'll show you, the initiative that led to the Global Psoriasis Atlas was that WHO resolution in 2014, which declared psoriasis as a severe non-communicable disease. And just to sort of also, before I start, what I was taught over the years is that don't accept the dogma if you believe that something is not correct as it's written or people talk about, then prove them wrong. And that's something that Lionel Fry taught me many years ago, and John Voorhees as well. And the other thing is you should always be curious. And I agree with Wolf Henning, follow your heart, because if you don't have a passion for what you're doing, you're not going to make it. These are my disclosures. That's what I'm going to talk about. I'm going to refer to the Global Psoriasis Atlas as the GPA, and I'm going to talk a bit about its history, its structure, our achievements now that we're in our 10th year, and the current work, ongoing work, and how the GPA has been used as an exemplar now for other atlases and our future plans. So for me, this started back in 2012 when my good friend and colleague Darren Ashcroft, who's Professor of Pharmacoepidemiology in Manchester, and I did this systematic review on the global epidemiology of psoriasis, looking at the incidence and prevalence. And this was one of the very first studies to look at this from a global perspective. And one of the things that sort of stood out from the work that we did was that there was a lot of gaps in our understanding of the epidemiology of psoriasis and no consistency in the way that the data was collected or analyzed. And at about the same time, I had the great privilege of being on the ILDS board, and the president at that time was the late Professor Wolfram Sterry, and he was very taken with what they'd achieved in the global mental health community, and this particular initiative called Grand Challenges in Global Mental Health. And he said, well, why should we have a Grand Challenges in Global Skin Health? And that's really what we tried to do. We had a meeting in London back in 2014, chaired by Rod Hay, and Matthias Augustin was there, and also several other epidemiologists included. And we sketched out what we thought were the grand challenges in global skin health. And what we wanted to do was to look at what areas should we focus on to really try and understand the burden of skin disease internationally. And we deliberately chose psoriasis as one to work on because A, that it was common. B, of course, if you're going to do anything in research, it's important to remember this, you've got to have the funding to do it. And we knew at that time that we'd get funding to do work on psoriasis because of the rise of biologics, as you've already heard. And so it's important to have great ideas, but also equally important to find money to prosecute the research. Then, as I've mentioned, the real sort of key that opened the door was the World Health Assembly on psoriasis in 2014, which is really a consequence of the lobbying successfully by International Federation of Psoriasis Associations. And of course, as soon as the WHO declares something as being important, they want to know much more about it. And as a consequence, there was this short 60-page report written on psoriasis by the WHO, which really laid out the roadmap, if you like, for research in understanding the disease better. And one of the areas that they wanted us to know more about was, of course, the global incidence and prevalence of the disease, with the ultimate goal of improving access to care for people with psoriasis wherever they may live in the world, whether it be Bolivia, Great Britain, or South Africa. And you sort of cast around as to how we're going to do this. And an initiative which had already been up and running for a number of years was flagged up to us by the WHO as probably the best paradigm, if you like, for a global atlas. And this was one that was set up by the International Diabetes Federation and now been running for more than 25 years. And you can see that any country in the world, any region in the world, one can get a fact sheet about the prevalence of the disease, the treatments that are available, mortality, etc., etc. Now, of course, psoriasis and skin disease is harder to digitize, if you like. Diabetes is a very numerical disease, a bit like a quantitative disease, the same as renal disease. Skin disease is a little bit trickier, but that's what we used as our sort of template. And our vision was to become the leading epidemiological research on psoriasis globally. And the collaborating organizations that helped put the Global Psoriasis Atlas together and who we still work with were IFPAR, the International League of Dermatological Societies, that's the LDS, and of course, the IPC. And we got initial funding through the Leo Foundation. So that's not Leo Pharma, that's their charitable arm, the foundation, for 3 years in the first instance. And one of the key outcomes from the first year program, or first 3 years of the program, was to launch the Atlas. This is the website. And the Atlas is a living document. It's not a sort of a book that sort of sits on the table and full of maps. It's actually a book. It's actually an easily accessed site that contains a lot of data, all our published papers, and of course the humanistic side and the personal side of having psoriasis. Now the core team itself is very small. This is the team. I'm the director. Darren Ashcroft has been the research director from its inception, and then we have a couple of research analysts or researchers, Alison Wright and Paul Dimmock, and then Tom Rogers and Alison Silk, who are sort of the key engine room, if you like, for the administrative side of the program. But the vast majority of the work that we do, as I'll show you, is done virtually, but also there are field studies as well, where we actually go out into the field and do very detailed research, and I'll tell you about that as well. But this is the sort of information, if you go on to, I'm sure you may be even looking at the site now as I'm speaking, but this is the sort of thing you get to know personal stories from patients with psoriasis, and then you can also get the data on whichever country you want to have a look at, the preferences as we currently know it. And we have a huge coordinated network. This is why this is what puts the global into Global Psoriasis Atlas. We have 140 countries where we have coordinators. So the burgundy color is our regional coordinators, and then we have national coordinators stretched across the world. And there's very few places now where we don't have individuals. Interestingly, there's places which are not so accessible, such as Sudan and Uzbekistan and places such as that. But the one place in Europe which stands out that we haven't got a coordinator as yet is in France. But pretty much other than that, we are very well covered, and even out into the Pacific Islands. One of the other studies we did in the first 3 years was this important systematic review, where we looked at the link between psoriasis and cancer, not just the ones that you might expect, such as skin cancers, which of course are in part due to the increased sun exposure that psoriasis patients have and UV exposure, but also the rarer cancers. And we were able to show that there was a link, particularly more severe psoriasis, with lymphoma, esophageal cancers, hepatobiliary cancers, and bladder cancer. And on the back of that, we then now published a study. I don't know if I have a picture of that now. Published a study where we looked at these particular cancers and psoriasis in Israel, Taiwan, Denmark, and the UK, and we found exactly the same, that these cancers are under the radar, but they do exist, and probably it's a need to be assessing our patients in even more detail, looking at the systemic associations of psoriasis. We started closer to home with our first prevalence study, and this was actually done in the UK, looking at the general practice research database, predominantly in England. And what we were able to show, and there's some interesting findings here. One was that the prevalence of psoriasis is increasing, but the incidence is staying the same. And that's because people with psoriasis are living longer. They still have shorter lives than the general population. But also we found that there was a latitudinal effect. We've just repeated this study just about a year ago. And if you move from the southwest of England down in Cornwall up to the northeast of Scotland, up in Aberdeen, the prevalence of psoriasis gets higher. So there's a latitudinal effect, and we've seen this also in Chile, which is, of course, as you know, is a long, thin country which stretches almost from the equator down to into Antarctica. You see, as the further away you move from the equator, the commoner the disease is. And we're not sure why that is, but there are other diseases which show that same latitudinal effect, such as multiple sclerosis. And then we moved on from the UK to look at the global picture. And we were able to say with certainty that at least 60 million people worldwide have psoriasis. We had good data at that time from 19% of countries. We've just repeated this, but we now know for certainty, taking into account self-declared or self-diagnosed psoriasis and physician-diagnosed psoriasis, that it may be closer to 100 million. And we now have good data from 1 in 4 countries and 25%. But there's still a long way to go. And a lot of the other data we extrapolate from country to country. But it's good to have this baseline. And the reason we do this is that if we go to a country, regulators or payers or governments and say, psoriasis is an important disease, you need to invest more in it. The first question that will be asked is, well, how common is psoriasis in my country? So this is an example of one of the first of this work. We've had very little data from sub-Saharan Africa. That's improving for sure, but we're still rather sparse. And there's only one good study which had been performed back in the 1980s by a dermatology registrar at the time who went from household to household in the lake area of northern Tanzania. And out of the 1,000 people that he examined, only one of them had psoriasis. So he could say, from the study he did, a sort of cross-sectional study, that 1 in 1,000 people had psoriasis. So we felt the first place that we should do a field survey was in Tanzania. And when you do such surveys, you need to have a very good team on the ground that you can collaborate with. And as you probably know, there's the Regional Dermatology Training Center, the ILDS set up 25 years ago now, based in Moshi. And they were our hosts, and we did a field survey with them, but also saw patients with psoriasis who they had collected over the years. We were able to get a real good snapshot of what the problems are. So here's the population, 57 million people, only 31 dermatologists. And the only systemic therapy they had was methotrexate. But most people, if they were put on methotrexate, they only used it for a few months because they couldn't get renewal because they lived so far away from the hospital. And then the other major finding that we had was that the diagnosis of psoriasis is missed and missed and missed by people working in the community, and it's usually misdiagnosed as tinea corporis. We did a small survey of skin disease in general. We saw no people with psoriasis out in the field. So maybe that original study by Dr. Gibbs was correct. But also we were able to publish the first ever skin disease survey of the Maasai people in northeastern Tanzania, which gave us an insight into the diseases that they suffer from. So the DPA has been important in allowing us to understand prevalence of disease of other skin diseases. So I mentioned that the accurate diagnosis of psoriasis is important, and Wolf Henning made the same comment. So this is, you can't do the immunophenotyping nanostring precision medicine out in the field at the moment, but so we need to try and improve the ability of community health workers to diagnose psoriasis accurately. Because particularly in skin of color, which is of course where most of the people we see in low and middle-income countries, psoriasis doesn't look like it does currently in the textbook. So we worked initially with the IPC. We did what's called a Delphi exercise, where there are 50 dermatologists from 27 countries who we sort of did a 3-round e-Delphi to sift down what we believe were the key clinical diagnostic criteria for the disease. And the central one, of course, is a well-demarcated lesion with or without silvery white scales. And it needed, but to make the diagnosis, you had to have at least 4 of the supportive criteria. And you'll see that number 1 mentions that in skin of color, diverse skin tones, psoriasis can look very different. And we now know that it doesn't just look a different color, there's also a different pathology. But if you gave that information to a non-dermatologist, it wouldn't really know how to deal with it. It wouldn't be able to improve the diagnosis of psoriasis. So we looked at another area of science, which is ornithology. And if you've ever been out in a park or in the country and wanted to identify birds, the bird book you take with you doesn't have photographs of the birds in it. It has artist drawings of those birds with the with the identification features highlighted, as you see here. So we got a very skilled medical artist to draw a whole host, paint a whole host of different presentations of psoriasis in skin of color, white skin, different forms of psoriasis, and use that in addition to those essential criteria, and then ran a study. This was during COVID, so we couldn't go out very far, so we could only do it in Manchester, but we looked at general practitioners, nurses, and pharmacists. And what we found was that the nurses, pharmacists particularly, improved their ability to diagnose psoriasis using this tool. We're now trialing this in a number of countries around the world, including the Netherlands, where we've just started with general practice there. But you think about global health as being going to the global south and hot, dry, tropical countries quite often. Well, the next study we did, next field survey after a gap because of COVID, was actually in Greenland. And this was a very remote part of eastern Greenland, which is only accessible. This village or this township in Tanzania was only accessible by helicopter. The sea was frozen even in May. And we worked closely with colleagues at the University of Copenhagen, such as Jacob Tyson and Klaus Nakaraya. And we did this study because the textbooks say that psoriasis doesn't exist in the Inuit population. So in this Inuit population, we found psoriasis. And the interesting thing is it doesn't look like the sort of classic chronic plaque psoriasis. There are also very few comorbidities. So the disease looks more like a sort of eczematous. It's nodular eczema-like. It's more like dandruff. It's not the big, thick plaques. So that's why it's important to go out into the field and collaborate and understand how the disease actually presents. And we wrote our first article. I don't think I'll ever write another article or publish another article in this journal, but the International Journal of Circumpolar Health. We then done studies with Professor Chun in Malaysia using their fantastic electronic health records and looked at chronic plaque psoriasis. And so for each study we do, we produce these infographics which are downloadable from our website. So in Malaysia, psoriasis has a prevalence of about 0.34%, but as you probably know, there are different ethnic groups in Malaysia, and we found that the highest rate of psoriasis was in the Indian population, followed by the Chinese and the Malay. Done a similar study in Taiwan, and what we found there is that, again, like we found in the UK, there was no difference in incidence prevalence of psoriatic arthritis, but what we did find is that psoriasis was commoner in men in Taiwan, and there were more patients who would normally expect to see who had presented later in life than we would see in Europe. And we also looked at risk of serious infection in these patients as well, and we're able to show that there's a higher risk of infection in psoriasis per se, not as a consequence of the drugs they're on, but severe psoriasis carries with it an increased risk of infection. And probably the most difficult study we've done is this one, which is in the Amerindian community in the Yanomami territory in the far northwest of Brazil, on the Venezuelan border. This is a population that is very difficult to access, only accessible by light aircraft. There's no roads, and the rivers are too fast and deep to actually navigate. And we looked at 555 people in 78 houses, so importantly look at all people in the village. And what we found was that there were no cases of psoriasis or atopic dermatitis or urticaria in this population. And of course, there's a number of reasons why that might be, one of which being genetic, or of course could be environmental. And we were able to partly test that hypothesis because the Brazilian government have a very good database of the indigenous people of Brazil, about 800,000 people. And what we were able to show is that as these individuals became more urbanized, you started to see the development of psoriasis and atopic dermatitis, implying that environmental factors, and we can discuss that, probably then trigger the disease. As you heard in the introduction, I have a charity which I founded with Dr. Sue Lewin, who's a colleague here in London, at King's College London, in Myanmar, Burma. We were unfortunately unable to get into the country for a number of years. We've just been there recently because they had a military coup there. But we found a way round educating the healthcare professionals in Myanmar by working with the IPC. And we ran an IPC masterclass in November 2022, the first one where we had non-dermatologists attending, and also we had representatives on the webinar from Nepal, Laos, and Cambodia. And that was very popular and very successful. And since we've just come back from, I seem to spend most of my time traveling, but just we did a study there out, educational workshops out there in February, and had over 250 people turned up, including there. So we now just come to the end of the phase 3. We still are interested in early diagnosis, still interested in epidemiology, and we are still interested in the health economics. One thing that we are looking at now we continue to look at psoriasis itself, but also generalized pustular psoriasis. And the most recent field survey we did was with Nakosa Delova, Professor Delova in Durban, in her home village, actually, in a very remote part of the Eastern Cape of South Africa. This is the Thinscape study, which was published in the BJD earlier this year. You can see where it is, just to get you orientated. And this was a study run at the end of December 2023, working with the local dermatologists and local community health workers. It was a difficult study to do in 2 townships, door to door. Sheer Azulent, who's on this call, was also one of the team members who joined us. And we did through these 2 townships. You can see the houses are very far apart. Not every house you can see in the bottom left, bottom right had human inhabitants. This goat didn't have psoriasis, by the way. And then we published, as you'll see, we have a little video that goes with this that came out with the BJD, and also this infographic. And the key thing is, as far as this psoriasis talk is concerned, not only do we have a good snapshot of the prevalence of any skin disease, but psoriasis, again, was rare. And when we did see it, it was often linked to HIV infection. The late Wayne Gulliver and ourselves have been working in his fantastic population of psoriasis patients, a very good database in Newfoundland. And incredibly, the prevalence of psoriasis in Newfoundland is close to 7%, but even more remarkably, there are 2 or 3 townships there where the prevalence of psoriasis is, this isn't a mistake, is 40% of the population. So we're doing further work in Newfoundland to really work out why that should be so common. Recent study from Poland using their databases, again, prevalence of 1.7. And then, as I mentioned earlier on, we're now looking at the annual prevalence of psoriasis again in the UK. I'm working with the Psoriasis Association, looking at the different ethnic groups in the UK. And as you might imagine, prevalence is going up, as I've mentioned before, because of the longer lifespans, but also it's commoner in the white population, 3.7%, rarer in Afro-Caribbean and Black African population in the UK. That's the first data that we ever got from that. And then you can see here, we sort of split it down a little bit further, commoner in Indian, rarer in the Chinese, a bit like we found in Malaysia. And the incidence has not changed, but it's the prevalence is going up because people are living longer. And then I mentioned that we're now working on generalized pustular psoriasis. So we went back to Professor Chun, who's a world expert on pustular psoriasis, and worked with her team on electronic health records, and did probably the first really good prevalence study of GPP in the world. And we found it's about 198 per million, so much less common than it is in the UK than the plaque psoriasis. And remember, in the ethnic groups of chronic plaque, it was common in the Indian population, rarer in the Chinese. Here it's commoner in the Chinese population, followed by the Malays and then the Indians. So let's just sort of close up here. What else have we been able to do? Well, Peter van der Kerkhoff and I, working with the GPA and the ILDS, were able to put together a very detailed documents, which we submitted to the WHO expert essential medicines list in 2024 to get make a case for adalimumab and ustekinumab biosimilars to be on the essential medicines list. And really very pleased that last year we were notified that we had got both of these onto the list, not just for adults, but also for children with moderate severe psoriasis. And that should improve the reach of these fantastic treatments. And then we've now just finished the Global Access to Care survey across the globe of the prevalence of the treatments that are available and how people with psoriasis access care. This had 3 dermatologists at least from each country. We've done 183 countries where we've got data now, and a lot of surveys, and we're just now trying to crunch the numbers, and hopefully we'll finish up with individual data sheets like I showed you for diabetes. There are very few countries do we have no data from now. It's quite a remarkable map here. And now we're sort of talking about how we're going to disseminate the survey and findings. The first survey and findings are going to come from Africa. And the success of the GPA has actually spawned other skin disease atlases. And we now have 3 others rather. The Global Hidradenitis Suppurativa Atlas, GISA, which is led by Gregor Jemik from Copenhagen. The Global Vitiligo Atlas, Global, led by Professor Ezzedine in Paris. And GADAR, the Global Atopic Dermatitis Atlas, led by Professor Carsten Floor from London. All of them have slightly different operating models, but we work very closely together. And the future field surveys, well, the next survey was the Philippines. We were supposed to be there last November, but an earthquake and a typhoon stopped us going. But it's now going to happen. And we're going out to Bogo City in Cebu Island in January, February in 2027. And then probably further atlases, further surveys will be in Senegal and probably in the Solomon Islands. I've just come back from the Solomon Islands where we've been doing some preliminary field work. These are the contacts. I'm the director, Darren Ashcroft, the research director, and then these are the other contacts. Tom Rogers is our program manager. And these are the people who funded us over the last several years. So